Hello, my name is Jonas Skogestad, and I'm the medical advisor in Norway for Sanofi. And it is my pleasure to welcome you all to this Nordic and Benelux Lipid Clinic meeting. And this is actually the 8th consecutive year that Sanofi, in collaboration with the Lipid Clinic at Oslo University Hospital, host this meeting. But it's actually the first time that we also have presenters and participants from Belgium and the Netherlands. So a warm welcome to all of you. And we are really excited about tonight's program, which includes a very interesting presentation on women and FH. And we also have a session with participants, presenters from all countries, presenting how they do FH diagnostics in their countries. And during the meeting, we encourage all of you to participate in the discussion in the chat, which you can find on the right-hand side of your screen. And with that, I give the word to the chairman, Dr. Martin Prøven Bogsrud from Oslo University Hospital. Martin?
Thank you, Jonas, and thank you, Sanofi, for initiating and organizing these meetings now for 8th year in a row. Also, thank you to all you participants and the speakers who make these meetings so interesting. Last year, which was the first year online, we said next year we will meet for real. But unfortunately, it's online this year also, but hopefully next year we can meet again. I would like to start this meeting by summarizing what I think is the 3 main challenges with FH. And then maybe the speakers will answer some of these challenges or how to deal with them during their presentations. The first challenge, FH is not diagnosed. In this study presented in one of our earlier Nordic Lipid Clinic meetings, we had collected data on statin use by the Scandinavian prescription registries. And the conclusion of the paper is disclosed in title, Genetic testing is essential for initiating statin therapy in children with FH. And as the figure shows, for the last 10 years, the black bars show the number of children diagnosed with FH in Norway, and the gray bars show the number of statin users among the children. And we see there's a close correlation between the number of diagnosed children and the number of statin users. Without diagnosis, the children and the relatives are not started on medication. Although the graph is increasing and almost 10,000 patients are diagnosed with FH in Norway today, we see it's still only half of the estimated number of persons. So we still have a challenge of many patients not being diagnosed. The second challenge is that even when diagnosed, there are lack of treatment options, as illustrated by these data from Norway. We investigated 714 adult FH patients who had been followed for as much as 11 years at specialized lipid clinics in Norway. Pre-treatment LDL was 6.7 millimoles per liter, reduced by 50% to 3.4 millimoles per liter with the maximum tolerated statin and ezetimibe dose, which is still far above treatment goal. A subgroup of these patients received add-on PCSK9 inhibitor and achieved a very low and nice LDL of 1.6. But due to the current strict reimbursement rules in Norway, unfortunately, none of these patients would have got PCSK9 inhibitor today. So these patients would then stop at LDL of 3.4, which is far above the treatment goal. The third challenge, what is actually FH? We have discussed this in previous meetings also. This study from Kera some years ago showed what we all know, that among persons with high cholesterol, there's only a very small proportion having FH. And the difference between genetic testing and clinical criteria for FH makes it possible that a person might have FH in Denmark or Sweden or another country, but not in Norway, for example. And this could be a challenge. So now we look forward to hear our speakers and see if they have solutions to some of these challenges in FH. Professor Holven and Professor van Lennep have been doing research on FH for many years, with special focus on children and women with FH. We know for FH that it's the cholesterol burden through life that matters in terms of risk. And we now are excited to hear if there are any difference between men or women.
Well, thank you very much, and thank you very much for the invitation to give this talk together with my dear colleague Kirsten. These are our disclosures. And first, to start off with, we can take a look at the woman's life course that starts from very early age onwards, when a baby girl is born, and then you have different stages that are special in a woman's life. For example, the menstrual cycle, which is unique for women. Then you have pregnancy, and then you have the menopausal transitions. And during this presentation, we would like to highlight several of these special female-specific stages and influence of FH in women.
So we know that it's the lifelong cholesterol burden that defines the risk of cardiovascular disease. But that means that also shorter and longer intermittent periods of either higher or lower cholesterol levels will also impact this later risk of disease. So it has previously been shown that in FH there is no gender difference in age at time of cardiovascular disease and time of death. Meaning in contrast to the general population, where there is an approximate 10-year age difference between men and women. And also, we've shown that the highest excess risk is among the young age group, and in particularly among young FH women between the age of 25 and 39 years old. From the Safe Heart study, we know that women generally are treated less aggressively. They have higher pre-treatment LDL and on-treatment LDL cholesterol. More women than men report statin intolerance. Women are treated less aggressively and with less co-medication. And fewer women than men reach their LDL treatment goal. So the reason for this lack of gender difference seen among the FH population, we asked the question if it maybe could be due to the fact that women accumulate higher cholesterol burden at younger age. So let's look at these different stages in a woman's life course. First, in the childhood. We have previously shown that girls have higher both total and LDL cholesterol from the age of 5 and up till the age of 20. And the difference were actually quite big. Girls have approximately 0.5 millimole per liter higher levels of cholesterol and 0.4 millimole per liter higher levels of LDL cholesterol. And that potentially leads to a higher cholesterol accumulation during these first 20 years of life.
Yeah, and then we'll go to the next stage, and that's the menstrual cycle. And this is an example of a very large study in 256 women who had twice their, during the menstrual cycle, during 8 times they had blood withdrawals. So you can see very clearly what happens during the menstrual cycle with the estrogen. The estrogen levels are the blue lines, and you can see that after we start with the menstrual phase, then the estrogen levels are low, and then you have the ovulation, and the estrogen levels go up. And later on, there's the luteal phase, and then the estrogen levels stay up, and also the progesterone levels increase, and then eventually they go down again towards the menstruation. And then in the black lines, you can see in the left-hand upper panel what happens to cholesterol levels, and you can see that they go up till ovulation, and then they decrease. Also, this happens with HDL levels and LDL levels. LDL levels are the right hand top panel, and then triglycerides are a bit of a blur. If you take a look, like it's only 0.3 millimoles per liter is the difference between the highest level, which is around the ovulation, and the lowest level, which is around the menstruation. But still, these are healthy women with normal cholesterols. But it's interesting to take a look like what happens in FH patients. And this is an ongoing study. And we measured here cholesterol levels in a woman who was not treated with statin before statin treatment. And I can tell you afterwards, we put her on the statin, so she has much lower cholesterol levels now. But you can see that these fluctuations are much more pronounced, and that it can differ even a whole point millimoles in cholesterol levels between the menstruation phase and the ovulation phase. And normally we never take this into account when we ask a woman to have a blood withdrawal, to ask her like, in which phase of the menstrual cycle are you? So actually, and this is like the desert of knowledge, so there's hardly any knowledge. We don't know anything or hardly anything about the influence of the menstrual cycle in lipids in FH in women. And also interestingly, if she is now on statin therapy, does this attenuate the effect on the lipid levels? So maybe afterwards it's not necessary to ask women specifically to have their lipid levels measured at a certain standardized phase of the menstrual cycle. But together with Kirsten, now we're doing this study, and we're collecting blood in several phases and in 3 phases of the menstrual cycle in FH women without statins and with statins. So hopefully we will replant this and solve this gap in knowledge.
So one of the next stages in a woman's life is the family planning and the pregnancy. So the guidelines recommend that all lipid-lowering drugs should be discontinued when pregnancy is planned, and during pregnancy, and during the breastfeeding period. And for women with FH, pregnancy really represents a dual exposure to increased cholesterol, because the woman is asked to stop statin already when planning the pregnancy, meaning that cholesterol increases rapidly up to pre-treatment levels, and then stay increased until pregnancy occurs. So the cholesterol accumulation has already started before the woman is pregnant. And then after the baby is conceived, the cholesterol level increases even further due to the physiological changes in pregnancy itself. So despite of knowing this, there is hardly any knowledge about the length of this period. How long does a woman discontinue statin in relation to pregnancy? So Janine and I, we set out to answer this question, and the data were just published a few months ago. And what we did was that we invited Norwegian and Dutch women with FH to fill out a questionnaire online and anonymously. And then we asked specifically about the time that they discontinued before they were pregnant and during the pregnancy, and of course when they started statin again after stopping breastfeeding. And in general, the women were 39 years of age, and most of them were genetically verified, and they have a mean of 2 children each. And they were 19 years at statin treatment start. Before I go into the results of the statin-free periods, I just want to draw your attention to this interesting finding that we also saw, that even among this very young group of women, as I told you, average age was 39 years. 8 of the women had already had a cardiovascular event. Most of them had had ischemic heart disease. And they had the first event at 40 years of age, mean. But again, you can see the range from 28 to 52 years old. So some of these women were quite young when they had a cardiovascular event. And very interesting, when we looked at when the time of the event in relation to the last pregnancy, we saw that for 8 of these women, the event occurred in relatively close proximity to the last pregnancy. So, but looking at these pregnancy-related off-statin period, we found that they stopped statin mean 2 months before getting pregnant, but again, a large variation from 0 to 34 months. And of course, they stopped statin during the pregnancy, which lasted in average 39 weeks. And then they started statin again 4 months after giving birth. But interestingly, we also noted that 30% of the women reported that they had used statin during some point in the pregnancy. Most of them stopped within the first 12 weeks, but a few had actually used statin all through the pregnancy. But in total, the total length of this, what we call pregnancy-related off-statin period, was 2.3 years. But not surprisingly, the periods, women having 2 children here in green or 3 or more children in orange, had of course longer off-statin periods than the women with only 1 child. And as many as 20% of the women had more than 4 years of statin-free periods related to pregnancy. When we looked at breastfeeding, we saw that both in Norway and the Netherlands, fewer women with FH breastfed, and they breastfed for a shorter time than the women in the general population. And also 22% of the women reported that they had stopped breastfeeding earlier because they wanted to start statin treatment. So to summarize, we found that young women with FH, they lose approximately 2.3 years of treatment in relation to pregnancy and breastfeeding. And for a woman of 31 years, that constitutes approximately 18% of lost treatment time. But as I showed you before, for some of these, there was a great variation. And for some of these women, the lost treatment time was considerably. And women with FH, they should be closely followed up and to minimize the duration of these off-statin periods.
And then we'll go to the next phase, and that's the menopausal transition. This is the SWAN study, and there they looked at what happens to lipid levels. In this case, it's LDL levels during menopause and after menopause. And what you can see here is that approximately the LDL levels go up about 0.5 millimoles. So that's quite considerable. And then something about, anti-Mullerian hormone, AMH, and that this depicts the ovarian reserve. And we know the lower the AMH, the earlier is the menopause. And interestingly enough, AMH, so the ovarian reserve, is negatively associated with subclinical and clinical cardiovascular disease, but there's also a negative association with LDL levels. Which is interesting in the case of FH. And here again we have the desert of knowledge, because actually we don't know anything about FH and menopause. We don't know if the age of menopause in women with FH is similar or lower or maybe even higher compared to the general population, which is interesting, especially given the association with AMH. But we also don't know what's the effect of the lipid levels of the menopausal transition in women with FH. Because similarly to what happens to the menstrual cycle, these were healthy women, and there the increase was 0.5 millimoles. But it could be that women with FH have even higher increases. On the other hand, if they're using statins, maybe this effect is also attenuated. And what's from a clinical point of view is very interesting is also the effect on statin treatment and statin reported side effects. This is personal experience, but I had quite some women who were perfectly doing well on statin therapy, but around menopause they reported that they had joint pain, they had possible statin side effects. So then, what I usually do is that I just have a statin holiday and see what happens. And very often they say, well, the complaints remain similar, so they go back on statin. But then if I specifically ask for menopausal symptoms, then it appears that it's around that time that they have also other menopausal symptoms. So it's also a very important clinical clue. So I would advise all FH healthcare professionals, especially if there's a woman who's been doing well on statins and is in the age that you could expect that there's a menopausal transition, to specifically ask for menopause. So actually, to take home, women with FH are understudied. The effect of the different life stages, important life stages in women is very important to have more research on. The influence of the menstrual cycle, also the influence of FH on pregnancy, but also of pregnancy on FH, and the influence of menopause on lipids and also on lipids management. And moreover, and what Kirsten in the beginning also found is that women are still undertreated. So I think it's also important to increase the number of women with FH who are treated to target. And then to finish this presentation, I would like to draw your attention on our new project, and you will hear about it very soon. It's a very exciting collaboration between FH Europe, the University of Oslo, National Advisory Board of FH, the Erasmus MC, and also LEEF, the Dutch foundation to find FH is joining, and we're going to have, in addition to our first Norwegian Dutch questionnaire, we're going to have a very large worldwide questionnaire for women and FH, and especially about the effects of pregnancy. So stay tuned and you will hear more about that, and I hope that you will all help us to encourage the women to fill it in. Thank you very much.
Thank you for this exciting talk and comprehensive overview of LDL burden factors or potential factors in a woman's life. But which of all these factors for LDL burden you think is the most important?
Oh, that's a difficult question because, of course, I think it's in the end it's probably it's a combination. But I would think that pregnancy and especially long-term off-statin periods will be important, but also the fact that women are not treated on target as much as men are is an important feature.
And are there any immediate actions we should go home and do now in the clinics to improve treatment for FH women?
But we think that just the new study that we just did, I think that has caused some attention, and that just now that more clinicians are more attentive to the fact that women should be more closely followed up than perhaps one thought before, because it has been sort of assumed that women always get cardiovascular disease later, and then this risk has been underestimated, perhaps among younger women. I don't know if you will.
Yeah, definitely. And I also think that it's important, especially because we showed in the study that sometimes it takes a while for a woman to go back on statins, and that it's important for healthcare providers to really make sure that after the breastfeeding is stopped, that women get their prescription and go back to statins. And sometimes they're so busy with other things that they just forget. So I think that as healthcare providers, we should take our responsibility and remind them to go back on the statins again.
Definitely. Thank you very much. Thank you. Now to our main session, improving detection and treatment of FH. Professor Kjetil Retterstøl, you have more than 20 years of experience treating FH patients at the Lipid Clinic and also research on FH. But even though these patients are diagnosed and treated, some of them do get coronary heart disease. Can you tell us why?
No, but I can discuss a little bit about if the risk for FH patients have changed the last 2 decades, and that is my focus here. So if we go back into the old days and we look at what Michael Brown and Joseph Goldstein had in their Nobel lecture in 1985, they said that FH heterozygous who carry a single copy of a mutant LDL receptor gene are quite common, accounting for 1 out of every 500 patients among most ethnic groups throughout the world. These individuals have a 2-fold increase in the number of LDL particles in plasma from the time of birth, and they begin to have heart attacks at the age of 30 to 40 years of age. And they also said that among people under the age of 60 who suffer myocardial infarction, about 5% have the heterozygous form of FH, a 25-fold enrichment over the incidence in the general population. So this is the calculation that you have 5% in the MI patients and 0.2%, that's 1 in 500, and the ratio is then 25. But if we use the modern incidence or prevalence of FH, which is more like 1 to 200, the risk is suddenly decreased down to 10. And if we look at Norwegian numbers here from the paper from Buxrud last year, they looked at patients with myocardial infarction before the age of 50. And they found that 3.4% had an FH mutation. However, almost 15% had clinical criteria of FH. And if you use the 0.2, 1 in 500 prevalence, you will find a risk of 17 by the same method as Brown and Goldstein used. But if you use the clinical diagnosis, you will find an increased risk of 74, which is very much different. So if you then change from 0.2 prevalence to 0.5, the increase change again. So you will then have a 7-fold increased risk for a mutation or a 29-fold increased risk for a clinical FH diagnosis. So talking about risk, we have to bear these things in mind. And if you look at the large Eurospire study, they reported that among 5 to 10% of those hospitalized for MI before age 50 had FH, and this was mainly clinical FH. That gives a fold increase for 25 to 50 if the prevalence is 1 to 500, but 10 to 20-fold increase if the prevalence is 1 to 200. So It is severely increased, that's for sure. But we can also look at it in another way. We can look at this in a prospective cohort study, where you can see people with FH, with this is the upper line, and the lower line is control population. And to the left you have women, and to the right you have men. And this was in the period 2001 to 2017, in a period where statins was very common. If you look closer into this, you clearly see that it is mainly in the young age that the difference in risk between controls and the FH is largest. You can see that when they are getting old, the control population will also have their infarction. But before age 60, there's very few people in the control population who have infarctions, and therefore the difference is so big. And don't look very good when you look at the excess risk for itself, and you can see that a 25-year-old woman have almost 20-fold increased risk. So when you see this picture, you really have a feeling that we should look more after the young. And this also applies to death. So if you look at people at the age of 20 to 39 years of age, it is a 6.6-fold increase in standard mortality ratio for cardiovascular disease. So is it no improvement from 1970? The numbers doesn't seem to be very different, although we had nothing like statins we had statins. It was not registered at that time. It doesn't seem like there is any change. This is excess risk of acute myocardial infarction in the period 2001 to 2017, and you can see that the excess risk is quite stable around a twofold for all ages put together. But then you should bear in mind that this is compared to the general population. So that raises a new thing that we should think of, and that is what about the general population? This is the curves of CVD death from 1951 to 2010 in Norway. The upper line is men, the lower is women. Both have about 80% decreased risk from 1970, and it's the same for most Western countries. But it's not the same if you look into, for example, Central Asia or Eastern Europe, because after the Soviet Union stopped to exist, we had an increase in the risk for the Central Asian and Eastern European countries. So remember, there is medication available, there is also procedures available, but there must be something else. In Norway, they said after the war we had some fat hunger, and probably the lifestyle is very, very important here. Back to the risk in FH, if we look at 2001 compared to 2018, we have almost a 50% decreased risk. So that leads us to conclude, or not really conclude, but suggest that the absolute risk in MI in FH patients seems to be reduced by 40 to 50% in Norway from 2001 to 2017. Looking forward, well, Martin has already underpinned that the underdiagnosis is probably the hugest problem. It is clearly a bad thing that almost 95% is not diagnosed. So this leads to undertreatment, of course, but it's also undertreatment in another aspect, and that is if you look at these numbers, it's a paper about the risk of recurrent cardiovascular event, myocardial infarction, after the first. So this is increased by 2.5-fold in people with FH compared to controls. So 2.5-fold increased risk in FH compared to controls. Why is that? Well, as Martin have said, the LDL cholesterol is too high. It's too high on treatment. And this is a study where we followed 350 FH patients. We treated them maximally with everything except PCSK9 inhibitors, and we could not come further down than LDL 3.0. So imagine that you have no FH, you are hospitalized with myocardial infarction, and you receive atorvastatin 80 milligram, and you are discharged with an LDL soon approaching 1.8. Assume the same thing. If you have FH, you are hospitalized, you are already on atorvastatin 80 milligram, and you come to the hospital, you are discharged with atorvastatin 80 milligram, and you continue to have your LDL 3.9. No surprise that they have 2.5-fold increased risk for a new myocardial infarction. So this has to be, something has to be done about this. This is, there's a lot of people working with FH in Oslo. This is the most important people here. Up to the right corner, you see a morning meeting at the lipid clinic, Monday morning. And within the dots, you can see my research group. And for this research, I would point to Karianne Svendsen and to Jannicke Igland, and Liv Mundal's picture has disappeared for some reason, but they have been instrumental for this data. Thank you.
Thank you, Kjetil. Very exciting and nice overview. When we talk about FH, we like to say that undiagnosed, untreated, it's very high risk, but when they are diagnosed, the patient, we promise the patient treatment and significant risk reduction. Are we promising the patient too much?
I guess we tend to do that, maybe, but there's also an important issue with compliance. So there's some of the challenges some of the responsibility is left to the patients also. But even though we may promise a little bit too much without being able to use the new treatment tools.
Yes, because with such high LDL, it's understandable that recurrent events happen.
Yes.
Yes. Some of the risk data are based on data from patients who got their diagnosis many years ago, when treatment was started late, for example. Do you think the risk in FH patients diagnosed now, today, are lower or better?
Yes, I think so. And that was also what we showed, because the excess risk followed the general population, and we know the general population has decreased the risk by about 50%. So that must also be the case for the FH patients.
Yes. Thank you, Kjetil.
Thank you.
Now, Dr. Kanstrup will tell us about FH organization in lipid clinics in Denmark.
Thank you. I'm going to tell you about the FH organization as regional lipid clinics, the way we have organized lipid clinics in Denmark. I have this slide with disclosures. In Denmark, we have 5 regions, and in those regions we have lipid clinics. In the northern part, only 1 lipid clinic, but in the other regions we have more than 1 lipid clinic. We have in Denmark 15 clinics, and all the general practitioners have the possibilities to refer patients to the lipid clinic. The lipid clinics are a bit different from region to region. In Aarhus, where I'm placed, we have 2 cardiologists, we have 2 nurses, and we have a dietitian. And we also have a pediatrician who is connected to the lipid clinics where we see the children. That's a bit different from some of the other lipid clinics. Some are not seeing children, and I know in the Copenhagen area, they are seen at the children's department. So they are a bit different around the country. In Denmark, there was a journal in 2013 that said only 4% were diagnosed with FH, 4% of those having FH. That's why the Health Ministry made a report in 2018 where they found that only 15% were diagnosed with FH. That's why everyone recognized you have to do something new if we were going to find all these high-risk patients. All other diseases where you only have diagnosed 15%, that is never sufficient. That's why we ended up making a database for familial hypercholesterolemia. It was approved in 2020, and actually yesterday we had the first meeting with the first pilot data from this database. It's made to monitor and hopefully to document improvements in detection and survival in patients with FH in Denmark. It's made up of some indicators, the indicators for diagnosing, indicator for cascade screening, for indicators for non-pharmacological treatment if they are referred for a dietitian. And we have also indicators for the pharmacological treatment, indicators for if the patients have reached their LDL goals, and also for the prognosis if they get cardiovascular disease. The data for this database, some of them are coming from our Progeny database. Progeny database is it's for the whole country. It's internet based, so all the lipid clinics can go to this database, and it's a working tool in our everyday work with all the pedigrees. So we have a place where we can find all the family members and see who's diagnosed, who's not diagnosed. And it's also possible for all the colleagues in other parts of the country, if they have cascade screening, to see which mutation is found in this family and see who are diagnosed. Some of the data for our national database are coming from this Progeny database, where we also have to fill in some extra information about Dutch lipid clinic criteria and some data about if they have been genetic tested. All the rest of the information for our national database, they come from all different registers. That's now we have a tool where we can monitor what's going on, but it's not doing all the work. As you can say, you can put the pig on a weight, but it doesn't do anything. You have to feed it if it's going to grow. So we have to feed this database, or it's not doing any difference. So where do we find these patients? They come from referral from general practitioners, hospitals, from acute care and rehabilitation departments after premature events, and also from cascade screening. General practitioners, they have their role in detecting these patients they have a big role, both in the future, but also by reviewing former cholesterol values, focusing on untreated values where LDL could be suspicious for FH. We have some general referral criteria. They are the same for the whole country. If a patient has 2 LDL measures above 5, they have to measure it twice. Or LDL above 4 if the patients are below 40 and there are a predisposition to premature ischemic heart disease. We want them to rule out secondary dyslipidemia. So that's what we tell all the general practitioners, that's the sort of people we want to see in the lipid clinics. What happens when they are referred to the lipid clinic? We make the pedigree, a family history, clinical history, physical examination. We find out if we think it's worth doing a genetic test. They get the diagnosis, treatment and follow-up, and also one of the main things in the lipid clinic is also the cascade screening from the relatives. How do we increase those referrals from the general practitioners? The general practitioners are in groups where they're obliged to make quality assurance projects. We have made some projects with general practitioners where they extract numbers of all the patients they have measured LDL values above 5, and then we made educational session about FH. And then the GPs, they went back to their own patients and found out which of those patients should they refer to our lipid clinic. This is from 2 of our GPs. They had 6,500 patients, and they found, by this method, they found 120 who had LDL above 5 at least once. They had an interview with all their patients to sort out if it was relevant, and 20 patients were referred to the lipid clinic. We found that was just from 2 general practitioners, and we found a lot of patients by doing this. So that's why we would like to do similar projects with other GPs in the area. We have made this one is how what happens to our referral after these projects with not just those 2 general practitioners, but with some groups. And we can see here that if you see the red arrow, that was when we were making those initiatives. And we saw a huge increase in referral. So we know that works. That's one way. Another way is putting articles about FH into journals that's made especially for general practitioners. We also have seen formally that gave us more referrals. We have to keep offering educational sessions to all the general practitioners so they are updated on FH. We have some plans about making a management program on FH. That's a paper made in collaboration with the general practitioners and cardiologists. And then this paper is put on the region's homepage. And that's where the general practitioners look when they are thinking about, how is the rules, which patients do we need to send to the lipid clinic? Then they have a place to look it up. Another thing we have found out help us to find more patients is years ago we just diagnosed at the lipid clinic, and then we said they could get their follow-up in general practice. But now the reason why we keep them now in the lipid clinic is because we want them to be more compliant, and we want to make sure that they get, if we get new treatments like PCSK9 inhibitor, we want to make sure that those people get them. That's why we keep them. But we also find out that it gives us the possibility to remind and re-offer their relatives if they are screened or not. Another initiative that we expect would help us also is that the general practitioner, they have got a new management program on coronary heart disease, hypertension, and hypercholesterolemia. This management program, they have a contract with the government, so they are paid for this work. And they make it a database where we can see here, this sheet, the first sheet here is on ischemic heart disease. This is not real patients, I have to say, it's just a demonstration page. The one is the sheet in the front here is the one with ischemic heart disease, and you can see they get a fast overview on their patients on what's the LDL value on all of these patients with ischemic heart disease. They have the line down here, so they can, it's in a fast way to see what's all my patients. Do they have, are they treated to target or not? It's easy to see, okay, this young person with ischemic heart disease with an LDL of 5.2, this might be a person we have to send to the lipid clinic. So we hope that this way, making an overview for the general practitioners, and that helps us, so they will also send the FH patients to the lipid clinics. Thank you.
Thank you, Constip. Very exciting to hear about your initiative, and very smart to get the general practitioners to be interested in FH, I think. In your database, you know how many patients have you now registered?
Yeah, I went to a meeting yesterday with the new numbers. It's not an official document yet. And to be honest, I don't have the exact number, but I recognize that they said 25%, and that was something new. 25% is now diagnosed in Denmark. If you think that 1 out of 220 has FH, so we can count it if there's 5 million persons in Denmark.
So that means if you said in 2018 you had 15%, then you almost doubled the number in yes.
I'm not sure that that it's because we have found so many new patients. I think maybe it's also something about the registration method. But now we have a way to do it in the future, at least.
Yes. And of these patients, you know how many of them have a clinical diagnosis and how many of them have a genetic diagnosis?
We don't have a number on that. That's not tested yet, so I don't know.
Oh. And I also have one more question about these GPs. You said the example where you found 120 patients and then 20 of them were referred to the lipid clinic. How did the GP choose which 20 of the 120 they would refer?
In the meantime, when they had those referral criteria and they had the education session, so it was from those criteria we gave where they needed 2 measurements, about 5, and they had to find out if they had secondary dyslipidemia.
Yes. Thank you. Now, Professor Demeur will present for us a Belgian screening strategy for detecting FH in the coronary patients?
Thank you. Thank you for the invitation to present this strategy that we have created in Belgium. As you know, FH remains underdiagnosed and undertreated worldwide. In the EuroAspir 4 study, up to 8% of adults hospitalized for acute coronary syndromes had clinical criteria compatible with potential FH. And we know that the patient with established cardiovascular disease and FH are at particularly elevated risk of recurrent events. The hospitalization of such patient for cardiovascular disease is a unique opportunity to initiate the first step of FH screening. In 2018, my friend Olivier Descamps published a consensus paper from a panel composed of Belgian cardiologists, endocrinologists, lipidologists, and also cardiogeneticists to better organize the practice of identifying and managing FH patients following acute admission to CCU. To reach such objectives, we developed an algorithm that splits each of the process of diagnosis, therapeutic management, and family screening of FH into 3 phases named Alert, Confirm, and Extend. It involves the efforts of several stakeholders, starting with vigilant doctors who suspect potential FH patients, then the expertise of an FH specialist, and later on the involvement of the patient himself as an FH ambassador. Identifying a potential FH carrier must be integrated amongst other priorities during a short stay and into the flow of all admitted patients. We recommend raising suspicion by a vigilant doctor based on 2 simple warning signs for FH, which should be checked in all patients admitted for incident cardiovascular disease. First one, LDL cholesterol level above 190 90 milligram per deciliter without treatment, or above 130 milligram per deciliter on lipid-lowering drug. And the second one is age of onset of the acute coronary syndromes or any other atherosclerotic disease before 64 years. We consider a unique age cutoff for both sexes to facilitate awareness and set at an older age than usual to be more sensitive. Premature family history is far too restrictive for screening at this stage in such an environment and should be assessed during the subsequent process. In the presence of these 2 criteria, the patient must be referred for a visit to an FH specialist. Visits to the FH specialist or FH clinic aim to confirm an FH diagnosis using DLCN score and/or to decide whether or not to prescribe confirmatory genetic tests. At the extend phase, a diagnosis of FH can be finalized using all confirmation data collected, including genetic tests if performed, to increase the diagnosis probability. For the therapeutic management, patients with established cardiovascular disease, as considered in the present algorithm, initiation of lipid-lowering drugs does not really depend upon confirmation of FH and must be implemented as early and as intensively as possible in order to achieve target LDL cholesterol, as per current European guidelines for patients in secondary prevention. In the confirm and extend phases, successive visits to the FH specialist also have as an objective ensuring drug compliance and adherence, titrating statins and/or adding other lipid-lowering drug. The process of family screening includes different objectives: raising awareness of familial predisposition to cardiovascular disease risk, collecting data on cholesterol values to calculate the LCN score, and cascade screening for FH. The patient collaboration is absolutely necessary at all stages, and they need to be motivated. The first phase is to alert the patient about the inherited predisposition to cardiovascular disease. The second phase is to encourage lipid tests in family member with the patient cooperation. In the extent phase, family screening must be promoted through the patient named FH ambassador. We have created a letter to family and GPs to increase awareness and promote screening. At the first step, we recommend assessment of routine lipids in family, and we explain that based on LDL cholesterol, it is possible to diagnose FH in adult relatives using the MET-PET criteria or in children using specific diagnostic criteria. The FH specialist must be ready to respond to queries and requests for advice of screened relatives or GPs. In conclusion, the aim of this consensus statement is to achieve a consistent management strategy for the identification of FH patients undergoing acute cardiovascular events, for the provision of treatment and the organization of cascade screening in relatives of patients hospitalized for cardiovascular disease in Belgian hospitals. Thank you for your attention.
Thank you very much. Very exciting presentation. As I could understand, you do genetic testing only in patients with this Dutch Lipid Clinic score between 6 and 8?
We don't only do the tests for this category of patient, but we promote to do in this category of patient, but we do also the test for the DLCN more than 8 and more to confirm the diagnosis and also to be able to screen the family who are not don't present a DLCN of 8.
Yes, so you always do the genetic testing if it's more than 8 then?
Yeah.
Yes. And this letter about family screening, you do that both for those with a positive genetic test or also in those with negative genetic test but clinical FH?
We do in the two categories of patients. We propose the cascade screening.
Yes.
And we do a project with a nurse who go at home of the family to promote the screening.
That sounds good. Yes. How large proportion of your patients you think have a genetic diagnosis compared to clinical diagnosis?
Probably half of the patient present a genetic test positive and half a genetic test negative.
Yes. Are there any of the patients having a high Dutch Lipid Clinic score which does not have FH? Or would you get FH diagnosis no matter what if you have a score of 9 or more?
Okay, can you repeat the question? Sorry.
I was wondering if you get the Dutch Lipid Clinic score of 9 or more, it's kind of a definite FH. But sometimes it could be if you have a St. Thomas, you get many points for that. But do you always consider more than 9 points FH, or would you sometimes say it's still not FH?
If I do the DLCN score, I consider that it's FH. Because if I put xanthoma in the DLCN score, I think that it's probably due to the FH.
Yes, thank you. Now we will hear about improved FH detection by electronic algorithms by Dr. Willem Baks from the Netherlands.
Mr. Chairman, ladies and gentlemen, I'd like to thank the organizers for inviting me today to speak to you about improved detection of familial hypercholesterolemia using continuous electronic health record screening algorithms. My name is Willem Baks. I'm an internist at the Department of Internal Medicine in Northwest Clinics, Alkmaar, the Netherlands. These are my disclosures. And I'd like to start off with the case of a woman who's 70 years old, and she visited our department for reasons of palpitations, and her medical history mentions a small myocardial infarction diagnosed elsewhere. She has all the usual medication, among which lipid-lowering therapy, aspirin, metoprolol, and fosinapril. Her total cholesterol is 5.4 millimoles per liter, and her LDL cholesterol 2.8 millimoles per liter. Now, this may look quite unremarkable, but I'm sure that you as experts are well aware that as soon as you know that the myocardial infarction happened when she was not even 60 years old, and the untreated LDL cholesterol is 7.0 millimoles per liter, this woman qualifies as suspicious of familial hypercholesterolemia, and she in fact needs to be tested because her DLCN, Dutch Lipid Clinic Network criteria, is 7 points. Because that is how we diagnose familial hypercholesterolemia according to the ESC guidelines. We first have a clinical picture in an individual patient. We count the Dutch Lipid Clinic Network score, and in case of 6 or more points, we want to consider genetic evaluation of FH for this particular patient. Now, we all know that over 80% of patients with FH go undetected worldwide. And we therefore hypothesize that automated medical record-based integration of lipid-lowering therapy corrected LDL cholesterol values can provide a signal to facilitate identification of familial hypercholesterolemia. And to do this, we analyzed the lipid-lowering therapy corrected LDL cholesterol values using a daily automated medical record detection routine. And for this, we have an electronic health record in the Netherlands in 60% of Dutch hospitals, which is called Higgs ChipSoft. So that's a pretty pretty good electronic health record, and it's used in many, many Dutch hospitals. We included those patients with an LDL cholesterol of 6.5 millimoles per liter or more after correction for the lipid-lowering therapy, and we excluded those patients with a previous diagnosis of FH and those less than 18 years old. The primary endpoint of our study was the number of patients with a DLCN score of 6 or more obtained from data that were accessible to the electronic health records. And the secondary endpoint was the additional number of patients with a score of 6 or more after manually adding data on patient and family history when available. In particular, family history may not always be as well recorded in electronic health records. Now, these are the results of our study. In 26 weeks, we were able to study or analyze almost 42,000 LDL cholesterol measurements. And of those 42,357 patients had LDL cholesterol that would qualify as 6.5 millimoles per liter or more after correction for lipid-lowering therapy. Of those 357, 42 patients would already have familial hypercholesterolemia, and 309 patients remained for our current analysis. Now, in the first row, you'll see the DLCN scores, and below that, you'll find the number of patients per DLCN score. In the row with the uncorrected LDL cholesterol, you'll notice that only 9 patients of those 309 would qualify as having 6 or more points in the DLCN score. However, if you automatically correct the LDL cholesterol for lipid-lowering therapy, this number would increase to 95. And if you'd add family and clinical history and physical examination, you'd end up with 127 patients. Now, of course, this is largely driven by LDL cholesterol correction for lipid-lowering therapy, which you can see in this slide, where the uncorrected LDL cholesterol is clearly lower on average than the corrected LDL values. Now, how does this work in clinical practice in our current electronic health records? We have this particular paragraph where all patients are shown, and you may add some extra items such as family history or items of physical examination, and it will calculate for you the total score. Now, by doing so, we are able to send a message to the physician who has ordered the LDL cholesterol, And this physician can then discuss with the patient whether or not they should do genetic evaluation. Now, the original scheme of diagnosing familial hypercholesterolemia has then changed somewhat, in that the first step of recognizing the clinical picture, in fact, is being done by the electronic health record. And after sending a message to the physician who's ordered the LDL cholesterol, they can do shared decision-making together with the patient whether or not they should go for genetic testing. We published this in atherosclerosis last year. And the question, of course, is, does it work? And it depends on the definition of what you mean by that. But what we did see was that last year, we saw an approximate relative 40% increase in the identification of FH index patients in our region. However, this is not very scientific, because we had COVID, we had very much variable numbers of LDL cholesterol being measured over time in the year. There were small numbers, etc., etc. But there appeared to be something. Moreover, GDPR legislation or privacy legislation prohibited us from direct checks with the patients involved. So we changed the question into another question, and that is, can facilitation of detection be improved? And this question we asked ourselves was more specific: to what extent would previously diagnosed FH patients in our clinics have been detected by the algorithm? And in that way, this would be some sort of sensitivity analysis. And for that reason, we included genetically proven FH patients, 208 in total, and we analyzed their data in the existing tool according to the methods which I just mentioned to you. And we analyzed the data in the electronic health records when also using alternative algorithms such as Simon Broom, MedPat, FAMCAT, and we compared it to the DLCN algorithm. Now, what I'll show you in the next couple of slides is the sensitivity of the algorithm. And I'll first go to the EHR, to the electronic health record accessible data. Of course, not all data, in particular family history, etc., is in the EHR in a coded way. And that means that Simon Broom and MedPat are very difficult to study, because they require the combination of family history and LDL cholesterol, and sometimes physical examination. And these, therefore, are not easy to obtain by studying EHR accessible data. So they are not studied in this first slide. And we looked at 2 time points, T1, which is the time of FH diagnosis, and T2, which is the first visit during recent years. And there may be a lot of difference, or very little difference, between the time of diagnosis, could be years ago, and the most recent time points. Now, we first studied the DLCN algorithm at the time of FH diagnosis, and we were somewhat disappointed to find that there was only relative, very modest sensitivity in this algorithm. In particular, the FAMCAT algorithm performed clearly better, and FAMCAT is also meant to be used for a population screening. If we looked at the other time point, the most recent time point, we found hardly any difference for DLCN, but clearly less sensitivity for FAMCAT. And we think that that is due to the fact that patients who've been known to have FH for a long time may have been treated with PCSK9 inhibitors, and PCSK9 inhibitors is not included in FAMCAT algorithm at this time. Now, we then looked at the EHR to the full potential. That is, we used all available data, and we also added some manually. We also added some other facts manually, such as family history, etc., etc. We found that Simon Broom and MedPat performed approximately similar to DLCN, and FAMCAT still performed much better than all others, to a sensitivity of about 85%. And we published this. We showed this at the recent American Heart Association meeting in Boston. Mr. Chairman, in conclusion, I'd like to state that electronic health record-based algorithms provide a promising opportunity to facilitate the detection of FH, in particular for physicians who do not often consider the possibility of FH. We think that the DLCN algorithm may be suitable for individual cases, as the ESC recommends, but FAMCAT appears better in population screening. We also think that inclusion of PCSK9 inhibitor use in the FAMCAT algorithm is likely to further improve facilitation of FH detection. I'd like to thank you for your attention.
Thank you. Very interesting to hear about your electronic algorithm to detect more FH patients. As I understand, among these 309 patients with LDL more than 6.5, then you said 28 had a Dutch lipid score above 8 when adding family history and the clinical examination. Yes.
128.
Okay. Did you also do genetic testing in these patients or only clinical diagnosis?
No, that's it. That's of course the main point, and that is what I wanted to say with the question: does it work? We don't know, to be honest, and we are hampered by GDPR regulations, by privacy regulations. We cannot contact patients that directly that were in this study. So I'd say that the most important finding of that study is the notion that it is very important to correct for lipid-lowering therapy. The patient that I show you may be quite unremarkable for many physicians, but after correction for LDL cholesterol and also patient history, I'm sure all of you experts and many other physicians will agree that this is a patient we need to look into. Definitely.
Will the physician for the patient participating in the study get this information?
Yes. We send them this letter that I show you, which is generated automatically. And in this letter, it was in Dutch, I apologize for that. It says, well, your patient had remarkably high LDL cholesterol. I'm not sure whether that is due to secondary causes, but I'm sure you will want to look into that and discuss with your patients whether or not this is due to secondary causes or perhaps even not taking the prescribed lipid-lowering therapy. So yes, it's after the letter, it's up to the physician to discuss with his or her patient whether or not genetic testing is actually performed. But as I showed you, we also saw, albeit rather unscientific, but increase in the detection of index patients.
Yes. And I think definitely informing the physicians about these patients must provide more patients with diagnosis, I'm sure.
Yeah, we think that too, and perhaps even the attention that is focused on the issue of FH could also add to identification of more patients. So it may not even be the tool itself, but the fact that physicians are made aware of the phenomenon of FH, that may already be something that could help us.
I just had one more question. Was this study like a one-time study, or will you continue in the future to inform the doctors?
Yeah, the thing is, as it's probably in many other European countries in particular, that privacy regulation does not permit us to go into patients' data too much. So we've had lots of discussion with lawyers, etc., and we think that completely automated responses can actually prevent us from breaking privacy rules. So that is why we wanted to adopt a better algorithm, and we are currently building this FAMCAT algorithm into our EHR. We have the DLCN FAMCAT incorporated in the EHR, but we are building the FAMCAT algorithm into the DHR. It's slightly more complicated than the DLCN algorithm, but as soon as we have that available, I'm sure that it can be done fully automated and thereby not breaking any privacy rules, which is of course very important and has our complete attention.
So now it's ready for our panel discussion. Thank you all for very interesting, exciting presentations. Earlier today, we also talked about the 3 main challenges in FH today: detection or diagnosis, treatment, and actually defining what is FH. So I thought I would ask by asking each of you, which of these 3 would you consider the most important challenge for FH? Would you like to start, Kjetil?
Yes. I think the most important thing is to find them, and it's not sufficient just to find them. You have to really find them so that they feel sure that they have FH and they really understand that they need to talk to their relatives, etc., so they understand that this is a lifelong thing. I think that is the most important.
Demeur?
Yes, if I can say, for me also the most important challenge is the detection of the patient, is the goal of our project Belfast to increase the awareness of the disease in the family, the GPs and in the specialists, to have a good detection of the patient is for me the main challenge actually.
Dr. Konstrup?
I agree. The first challenge is to diagnose the patients. If you haven't diagnosed the patients, you are not able to treat them. And we know that we are far from where we should be in Denmark, with maximum 25% diagnosed. So we have a lot of work to do just to find those patients.
Professor Box?
Yeah, I couldn't agree more. The finding of the patient is the essential thing to do. But the point is, we can't do it ourselves. I think the awareness among GPs and among, the public, the entire population in the country should be increased, so that also people who may look not as suspect of having FH can also be diagnosed to have FH. A simple LDL of, say, 3.4 millimoles per liter under heavy treatment for lipid lowering is not a normal LDL. And that is going to be our challenge, I guess.
Yes. Yes, I agree with you. I think when we started our advisory unit some years ago, we had the same discussions, what is most important. And we decided that diagnosis and detection would be, because maybe we should educate doctors first, they would be ready to have the patients, or we should make lipid clinics bigger first, but we decided just to start with detection. And then when the patients are diagnosed, then the hospitals have to take care of them. So I think also detection and diagnosis is even maybe the most important. But then on the other hand, also now when we have detected so many, I think it's frustrating that we cannot treat LDL even lower with the current reimbursement policies. It was easier some years ago when you didn't have the next option, but now having an option, not allowed to use it, is difficult. You agree, Kjetil?
Yes, so but let me ask you, let's say if you if you find FH and you start treatment at the age of 8-10 years, and you manage to have the LDL down to 3 or 2.5 maybe, would you worry? Or do you think that will solve the whole FH problem?
Who wants to comment?
Well, I can comment on that. I think the detection itself at early age is an important issue already. I think a lot is being done when you find the patient and treat them at early age, say 10 years of age, and or 8 or 10 years of age. And the level up to which you want to treat them is probably dependent also on reimbursement regulations. And what the patient would want to have, but we would aim at 2.5 minimum maximum for them to be treated. But I was somewhat surprised to hear that a beautiful and also rich country like Norway doesn't have the reimbursement for the PCSK9 inhibitors. In our country, fortunately, we're able to treat FH patients with sufficiently high cardiovascular risk with PCSK9 inhibitors. Well, they all have sufficiently high cardiovascular risk. So that really has improved the treatment of FH patient over, last 5 or 10 years.
You're lucky.
Yeah, we are. We are.
I think also it's important that you diagnose early, because if you have a child and you start treatment at 10 or 12 years and you treat to a target about 2.5, then that person won't have that much cholesterol when they get older. And also, if you have diagnosed them early, they know a lot about healthy lifestyle. They have been told for so many years, don't start smoking. You have to have a healthy lifestyle. You have to do sports. So I think they are not that in that bad condition if they are diagnosed early.
And for diagnose early, I think that it's important to increase the awareness of the family when we detect a patient, to make the cascade screening of the family. We know that when we detect one FH, we probably be able to detect 2 or 3 more patients in the family.
That's very important.
There's a beautiful study from Amsterdam University in the New England Journal, in which they actually showed that you can practically abolish the excess cardiovascular disease in FH patients when you treat them early. Was quite remarkable to see the 100%, which is of course not possible, but enormous effect of treating early, for which you have to know that they have FH, of course.
Yes. And that leads on to my next question. I think many of our detection programs are aimed at detecting FH in patients who are maybe already coronary diseased or adults. But in order to prevent early disease, we should then find their families so they can start early treatment. In Norway, with genetic FH, we think it's easy, because then if you have the mutation in the family, you can get genetic counseling and test, and there is like a good system for it. But when we have patients with a negative genetic test, but still a high cholesterol and maybe some thing in the family, we don't have that much of a system, I think. How do you do it with the FH, clinical FH with no mutation? How you test the family?
I think in Denmark we do sometimes. It's much easier if they have a positive genetic test. Then you know exactly what to offer. And if you don't have the positive test, you should also make the cascade screening for the relatives. And we do that in most cases if they have a high score on the Dutch Lipid Clinic score. then we would offer cascade screening also to those patients.
Those with negative genetic test.
Yeah.
Yes.
But can I ask you something? But by cascade screening, you then mean you investigate their cardiovascular risk profile instead of genetics, or do you actually do genetics even when you haven't found them in the index patient?
When you have found the index patient, then we offer the first degree relatives. They have a lipid profile as a cascade screening.
It's not the genetic. But you don't do the genetic test.
We do the genetic test, and also always, if they have a positive genetic test in family, we offer genetic test to all the first degree relatives. But in those patients where you have a negative genetic test, but you can see this family, they have an LDL of 5 or 6, and they have cardiac disease in early age, so we think they still have FH. We are just not clever enough to get the right diagnose genetic, and those relatives, they are also in a high risk.
Yes, we do the same in my country, in my clinic. We test all we do the cascade screening in all the family. We don't do the test if the first patient is negative, and we propose high intensity treatment on the patient with high level of LDL cholesterol.
But if you want to, in the case concept you said, when the patient, when there's a negative genetic test and you want to do the clinical evaluation of the relatives, do you do it yourself in the lipid clinic, or does the patient's relative have to go to their own doctor in some way?
It depends. If it's a quite clear case of you think it's FH, if they have a score on Dutch Lipid Clinic or on, for example, 6, then we would offer it at the Lipid Clinic.
What do you do in Norway, Kjetil?
I think the way it is done here is probably the common thing to do in the world, and I think you will get quite good accuracy by, at least in children, checking the cholesterol value. So what we do, I think we were more clever to do that before, but that was to give them laboratory sheets to the patient and ask them to give this to your brother, to your sister, to your children, etc. Go take the blood samples and we will have the answer. Then we can look at the answer and we can write a letter to the patient and say this or that. So that gave us a little bit more control, because when you say go to your GP and let your GP fix it, we know for sure that there's a lot of loss of follow-up, to say it that way. So of course there are lots of follow-up doing it the way I say too, because people forget to give the laboratory sheet and things like that. But at least, yeah, I don't know what is the best thing actually, but at least then we had the answer and had a feeling of control.
If I can add something.
Yes.
In my country, we have proposed we have created a letter for the patient and for the GP. We have finalized this year, and when we detect the patient, we give this letter a number of sheets for the patient to give to all the members of his family. And in this letter, we explain the disease, we explain the risk, and we have a second part for the GP of the patient, of the member of the family of the patient, to give to his GP to explain how to do a good screening with the MedPet criteria to probably detect the FH in the family with the level of LDL. It's the way that we are working this year.
When we talked about three challenges in FH detection, treatment, and actually defining FH, Retro, you told me I forgot one challenge, and that is even though you have been detected and even though you have treatment available, if you have a low compliance, and that's also a challenge.
Yes, I think that might be an increasing challenge in the future, because now today most of the cases have seen maybe not the parents, but at least their grandparents having a premature cardiovascular disease. But when even these grandparents are well treated, they may not see anything like cardiovascular disease. They just hear about some theoretical number, cholesterol level, what's that? And why should I take pills and things like that? So that will be a challenge for us to explain them the disease when they haven't seen any consequences. But that's in the future problem. Do you have problems with patients not being compliant, let's say youngsters or young adults, etc.?
It does happen, but you're right. As soon as people remember the family members who died prematurely, they will be motivated. But those are not the problem. But I think that the problem is in patients who that's a form of compliance. Also, if you know that your brother has had premature atherosclerotic disease that you do not test, and so the once they've actually been diagnosed, in my experience, people are fairly well motivated to go for treatment. But the treating of cholesterol is only one. I mean, they will have to be treated for lifestyle aspects and for blood pressure, etc., etc. So, and cholesterol may be easy in some patients, but the other lifestyle issues and blood pressure issues may be much more difficult to treat in some. So it's a complicated matter, but motivation in those who've been diagnosed and those who still remember the family members that they lost prematurely, that's pretty good in my experience.
I think we have to keep educating the patients so we are sure that they know why they should take the medication. And also, I think it's important to keep the contact, maybe not too often. We can't have a full day with FH patients who are well treated, but see them with years between, so to make sure that they're still having their medication. I think that's important.
So how frequent do you usually see an uncomplicated FH patients? Do you have any rules?
It depends, but in the beginning we see them until they're treated to target, and then we say they have to go to their own doctor at least once a year, and then after 3 or 5 years we see them again at the lipid clinic. Or it depends, we look at how old are the children, when would it be time to make a reminder for the parents to have the children screened, so we put an appointment with the parents at that time sometimes.
And so maybe the clinical diagnosis for FH will be even more challenging in the future, since the parents then have no premature heart disease.
They won't have any points at the Dutch lipid score, at least.
That's good. But I think we almost used our discussion time now. So thank you very much for interesting discussion. And we also identify the fourth challenge in FH with compliance. So, but we have to focus first on the diagnosing, detection. I think we all agreed that would be the most important challenge to do first.
Thank you, Martin, for guiding us through this exciting meeting. It is always a pleasure to be part of this meeting, and particularly when we have such high scientific quality. And I hope that what you've heard tonight might have stimulated some new ideas and potentially could lead to some improvement of patient care. And I would like to thank all the presenters and the chairman, Martin Bogsrud. I would also like to thank the program committee consisting of Professor Retterstøl, Professor Holven, and Dr. Martin Bogsrud. And I would, of course, like to thank the Lipid Clinic at the Oslo University Hospital for a great collaboration over many years. And finally, I would like to thank all of you that tuned in, and I wish everyone a peaceful December and a good night.